why am I here? Well, I'm a chap who spends most of his time in the intensive care unit, in the anaesthetic room, in the operating theatre, giving fluids to people and wondering why things happen or why things don't happen as I would expect. And I'm going to kick off too with a little tribute to Starling, a picture of him there with a statement that the absorption of isotonic salt solutions by the blood vessels is determined by the osmotic pressure of the serum proteids. This is a picture of him clearly in older age, doing what I expect he was doing every day with an anaesthetized dog. The anaesthetist will recognize the anesthetic equipment to the right-hand side of the picture there. And this is actually a photograph taken in 1903, and it's a reconstruction of an experiment going on in the laboratory. Because, I'm not going to go into this in great detail, but there was an enormous scandal, the brown dog scandal. And it was alleged that this experiment was being done with the animal inadequately anaesthetized. And just to give you a little interest, this was the lady who made the allegations. She pretended to be a physiologist. She was actually a Norwegian anti-vivisectionist. This is, you hopefully recognize from Charles' pictures, that over there is Bayliss, this is Dale, and that's Starling. And Bayliss, as we've heard, worked with Starling on a treatment for wound shock during the First World War. And they tried all sorts of colloids, and one of the colloids that they tried was gum acacia, so they were giving gum saline. That too is a fabulous paper to read to give you the history of wound shock and the contributions that it made. But the author of this particular paper, William van der Kloot, said, today the colloid osmotic pressure in transfusion solutions is usually provided by dextran or human albumin. Vast quantities are used, but Bayliss's role in the development of this clever biophysical therapy has been almost forgotten. Alison Twigley was my registrar at Charing Cross. Ken Hillman was my first intensive care consultant. And when they published this paper in 1985, showing the body water in 3 buckets, the intravascular space, the interstitial space, and the intracellular space, I couldn't believe my luck at how simple physiology was. And in the time that, over the 20 years that that's been around, getting on for 30 years now, isn't it? The only thing that has really changed is that the box is now shown in 3D rather than as a flat set of buckets alongside one another. This paradigm takes no account of the circulation of extracellular fluid. And this is a survey that was done in 2009, looking around the world at how anaesthetists in intensive care units use fluids for resuscitation. Every time a patient was deemed to have become hypovolemic and to need a fluid poured into his veins, they filled out a little form about how they did it and what fluids they used. Did they use blood? Did they use plasma? Did they use albumin? Did they use a synthetic colloid? Did they use a crystalloid? And taking Canada as a boring average, that's the red line second across there, as a compared to them, what is the odds ratio for receiving a crystalloid in any single resuscitation episode, we'll find that compared to Canada, if you are in New Zealand, you are 3.5 times more likely for that resuscitation episode to receive a crystalloid. New Zealand were the leading crystalloid users. The Americans are over there with them as well. And then at the other extreme, those who give less crystalloid than Canada, we had China, and almost as a strong outlier, we had the United Kingdom, where your odds ratio for getting a crystalloid was 0.3, less than a 1 in 10 chance that you would be given a crystalloid to resuscitate you from your hypotensive episode. Which is strange because, you know, when we first got pulmonary artery catheters, when we were first able to measure capillary pressures in humans and cardiac output, people were doing some interesting studies and they were coming up with some interesting conclusions. This is Virgilio from 1979, looking at patients having aortic surgery using an isotonic salt solution, Ringer's lactate, or a colloid solution, 5% albumin in Ringer's lactate during aortic surgery, replacing losses and monitoring the wedge pressure, monitoring the cardiac output, monitoring the urine output, trying to keep the patient stable. And they found that they needed twice as much crystalloid as colloid, which wouldn't surprise us these days. and finding that the colloid osmotic pressure in those who did not get any colloid dropped by 40%, a 40% drop in the plasma colloid osmotic pressure. That should have caused edema. But the only patients that got edema were in the albumin group. The only patients that got pulmonary edema had a normal colloid osmotic pressure at the time that happened. They were therefore able to conclude there is no need to maintain the plasma colloid osmotic pressure by using protein-containing solutions during hemodynamic resuscitation when you're titrating to physiologic endpoints. And then a little while later, a double indicator dilution technique came along that enabled us to estimate the lung water. I was privileged to have a lung water machine to play with when I was a research registrar in Glasgow. Fascinating device. I couldn't believe that it would actually do what it did, but it does measure the lung water. And here we've got Shires, who added a lung water measuring device to his investigations into patients undergoing aortic surgery. He too confirmed that the Ringer's lactate group required twice the rate of infusion of the plasma group, but he observed by the days 1 and 2 they had more urine output, they were getting rid of it. And he also observed that despite the steep drop in the colloid osmotic pressure of plasma, lung water did not change. And they too were able to conclude that crystalloid resuscitation to physiologic endpoints does not cause pulmonary edema, and manipulation of plasma colloid osmotic pressure was unnecessary. This is leaping forward to as recent as we can get, and in Holland, Johan Groeneveld has got a large data set of patients in his intensive care practice who are undergoing resuscitation while being invasively hemodynamically monitored. And he observed in his paper that although pulmonary vascular permeability, cardiac filling pressures, and colloid osmotic pressure should, according to the Starling equation, predict an increase of lung water, their predictive value in clinical practice is poor. And his conclusion was that extravascular lung water increases during fluid loading in the critically ill is best predicted by a plateau of cardiac function. Give the fluid until the stroke volume no longer increases. And if you go beyond that, you will cause pulmonary edema. That, felt Groeneveld, was the real clinical take-home message if we are trying to prevent edema. And this is a paper from this year from York, where they have patients undergoing major surgery whose stroke volume is adjusted by giving boluses of fluid during the operation, and they randomize the patient to get either an isotonic salt solution, a crystalloid, or to get starch, a colloid boluses. And this was really one of the very first studies to do this in any particular detail. And one of their interesting observations was that after the initial bolus of trial fluid, the hemoglobin level in the starch group was lower than the hemoglobin level in the crystalloid group. They didn't do the oxygen delivery calculation. I've presumed to do that for them and charted it for you there. And you will see, surprise, surprise, that the patients who got crystalloid boluses to maintain their stroke volume had at all times better oxygen delivery to the tissues because they were not made so anemic. But their stroke volume was maintainable if you used just a 1 to 1.6 ratio. You needed 60% more crystalloid than colloid to keep the circulation going, but it wasn't the sort of threefold, fourfold that is anticipated if you believe in colloids for the plasma volume, crystalloids for the interstitial, for the extracellular fluid generally. I don't know, I have links with all these places. I spent a year in London, Ontario, and this research was done while I was there, although I wasn't directly involved with it, and it is ovine research. It is done on sheep. These sheep did have their lymphatics cannulated. They were given peritonitis, and they were observed. And what's interesting here to point out, there was a little bit of a fall in their stroke volume index, but it recovered. Their heart rate went up. Their mean blood pressure remained unchanged during this experiment, but they did greatly increase their lymph flow and their albumin clearance. And because the concentration of albumin stayed fairly constant within the lymph as it increased, they concluded that systemic sepsis results in increased peripheral microcirculatory fluid flux that is primarily a consequence of an increase in permeability of the peripheral microvascular exchanging mechanism. This too is a very key paper, and yes, I spent a year in Glasgow as a research registrar with Adam Fleck, Gail Rains, Felicity Hawker when this experiment was done. The rate of loss of albumin to the tissue spaces they found, these are patients in our intensive care unit, patients on our cancer ward, patients after cardiac surgery, radio-labelled albumin, how quickly does it leave the circulation? The rate of loss of albumin to the tissue spaces is normally 5% per hour, which is more than 10 times the rate of synthesis and catabolism. And these large rate increases indicate that increased vascular permeability is an important cause of the lowered concentration of albumin commonly seen in acute and chronic disease. And I'm grateful to Charles and to Rodney Levick for this quote. I've given you there the opportunity to read it slightly fully, because when I stand in front of you and tell you that the three buckets picture of plasma, interstitial fluid, and intracellular fluid is something that we really have to give up on, I am well aware that doctrine once sown strikes deep its roots, and respect for antiquity influences all men. Still, the die is cast, and my trust is in the love of truth and the candour of your cultivated minds. Kenton was giving us all the pictures. This is one that I like that inspired me when I found it. It showed me a tight junction. I thought, let's have a look at a tight junction. Let's have a look at an intercellular cleft. And I thought this picture showed it nicely. At the top left in A there, you can see the lumen with its fluffy glycocalyx. You can see the cell membranes, and you can see them kissing in picture A there at a tight junction. No longer kissing in B or C, but then again kissing in section D. And where they are not kissing, that is where there is a gap between for fluid to pass through, so that it's possible for fluid to leave the circulation through the glycocalyx and through these infrequent discontinuities, as my physiology friends call them, gaps as I think is nicer, in the tight junction strand of endothelial clefts. Right. And we have, this is Adamson and Sheldon Weinbaum. This is an experiment that I think confirmed what Charles and others had been saying about how we have to interpret the Starling equation. We hypothesized that ultrafiltrate crossing the luminal endothelial glycocalyx through infrequent discontinuities in the tight junction strand of endothelial clefts reduces albumin diffusive flux from the tissue into the protected region of the cleft on the luminal side of the tight junction. Thus, the effective oncotic pressure difference opposing filtration is greater than the measured between the lumen and the interstitial fluid. Here's another diagram to point out that the key observation is that albumin is filtered at the glycocalyx. The ultrafiltrate has a very low concentration of albumin and is funneled into the infrequent breaks, the gaps, in the junction strand, so that the water velocity at these breaks is very large. It opposes the flux of albumin from the tissue back up towards the glycocalyx. And it does that even when filtration rates are quite low. So I've taken the liberty of animating this a little bit to show you that as we reduce flow, the albumin is able to diffuse back from the interstitial space further towards, let me see if I can point with this, further towards the glycocalyx, which is here. The albumin can come back up to this protected zone here, so that at very low flow, the albumin or the protein concentration under the glycocalyx is getting closer and closer to the protein concentration in the capillary, and therefore the gradient that opposes filtration is going down and down and down. Moreover, and if we put this in the anaesthetic exam, and this will have to be a gold medal question, the interstitial fluid space here could be quite a large one, but it's kept as a very small microdomain, it is hypothesized, by the presence of pericytes, which lay very close to interendothelial clefts. We see a lot of these within the brain, fewer in other parts of the circulation, I am told, because I'm an anaesthetist and a medical lawyer. Why did I come to write this paper? For 20 years I'd been giving the final fellowship course lecture at the Royal College of Anaesthetists on fluid therapy, and I was diligently reading every year what scientific papers I could find, what clinical papers I could find, trying to make it intelligent, trying to make it realistic, but realizing all the time that a lot of what I was saying just didn't hold water, was easily challengeable, really didn't make much sense. But then, as the candidate said, all we want you to do is to tell us what we need to say in order to pass the exam. The audience I was lecturing to weren't particularly interested in whether my theories were getting crazier and crazier and crazier. And I eventually, having, I think the final straw was when I read Charles's 2010 review article with Rodney Levick, crying out for us, please, to understand that the Starling equation or the Starling principle has moved on. I was very, very fortunate in having a son who, as he tells me, is a real doctor, a real scientist. He's got a PhD. He's a neuropharmacologist, I suppose is the best way of describing him. He's just finishing his work at Macquarie in Sydney on syringomyelia after traumatic neck injury. How does that occur? He's off to America now looking for a job. If any of you know anyone in America who wants a really bright neuropharmacologist, here he is. But he spent some months with me in England. We did a bit of trout fishing, we did a bit of beer drinking, and we did a bit of talking about this glycocalyx theory and how it might affect me in my anaesthetic practice. And we eventually got something together, which we eventually persuaded the British Journal of Anaesthesia to publish. I'd been inspired too by the work of Robert Hahn, a chap who over a decade had been pouring crystalloids very fast into people's veins and looking at the dilution of red cells and deducing from the acute dilution of red cells what was happening to the plasma volume, or as he more correctly put it, the central volume of distribution of the fluid that he was infusing. And there's his standard pharmacokinetic diagram showing that what you squeeze into the central volume of distribution it comes into equilibrium with a peripheral volume of distribution, and you have to take into account what you're pouring in and what's coming out. All really very simple stuff. This was fascinating. He found, after many experiments, that there was something he called context sensitivity, that the elimination rate of acetated Ringer solution in this, the measure depended on the situation you were in. Healthy volunteers, if you pour in Hartmann's at 100 mils a minute, it goes to the circulation at 100 mils a minute. Pour it in, straight out. Preeclamptic women, they get rid of it even faster. Well, as you know, as we anaesthetists and doctors know, they're very edematous and they're very prone to get cerebral edema and fit. But normal pregnancy patients, actually, you pour that litre of Hartmann's in and it doesn't come out so fast. It stays in the circulation longer. People who are anaesthetized, undergoing thyroid surgery, undergoing laparoscopic cholecystectomy, the elimination clearance of a crystalloid is very, very low. Now, Hahn at this point hadn't done colloids, but someone in Korea did. So I take this with a pinch of Korean salt. But in healthy volunteers, they found that hydroxyethyl starch poured into a healthy volunteer had an elimination clearance of about 7. It's about the same as a healthy patient receiving a crystalloid while they're under anaesthesia for a cholecystectomy. And this is fascinating, that they found the clearance increased when they anaesthetized those exact same people. So they measured these people awake and healthy and then anaesthetized them. And they found that the clearance of hydroxyethyl starch solution went up. I can't explain that one. Charles has set the ground for me in telling you about Stavelman's reflection coefficient sigma. And we now, as you've heard, it modifies the measured osmotic pressure difference delta pi to the effective delta pi in the Starling equation, and is strongly expected to be probably a characteristic of the glycocalyx and its interaction with plasma proteins. At steady state, the hydrostatic pressure difference delta P driving filtration is always larger than sigma delta pi. So capillaries produce filtrate along their entire length. This is the steady state no reabsorption rule, or the Michel-Weinbaum model. And sigma delta pi opposing filtration is much greater, and so transendothelial solvent flux, JV, much less than previously believed, and the ultrafiltrates is almost all returned to the blood circulation as the flow of lymph, Q lymph. Yes, I bought a textbook on fluid therapy last year, and there was the chapter on fluid exchange, and yes, it carried the standard explanation of filtration, reabsorption, and in that particularly expert book pitched at a clinical market, but that chapter written by a respected physiologist he really had probably either not heard of or did not accept the new revision of the Starling equation, but these authors did. They conclude that the lymphatic vasculature provides the only escape route for extravasated fluid and macromolecules. It's not the first time it's been presented to a clinical audience, because this paper was actually put together for one of Europe's biggest intensive care meetings in Brussels, presented in March 2011 there, to an audience of possibly thousands of intensivists. So this message is being put out. So here's my first practice point for anaesthetists, that the steady state no absorption rule, the Michel Weinbaum model, for me, explains why biophysical infusion therapy to raise the plasma oncotic pressure has much less effect on plasma volume and on tissue edema than the traditional filtration absorption balance interpretation had led us to expect. If, by increasing the colloid osmotic pressure of the plasma, we do not reabsorb fluid from the interstitium into the vascular space, well, it's not going to work, is it? All that a higher colloid osmotic pressure can do is to slow down the filtration rate. But it only slows it down, it doesn't stop it. And so I sort of, cadging a little bit from harm, drew this particular diagram, sit down with a piece of paper and a pencil and start trying to work it out. That what we've got, rather than the adjacent boxes, is a system in which enteral fluid is absorbed into a central volume of distribution, is then in equilibrium with the peripheral volume of distribution, and a return as lymph. This central volume of distribution you can think of, I suppose, as the plasma volume, but I think it's a bit more complicated than that. And this peripheral volume of distribution you can think of as the extracellular fluid, but again, it's a little bit more complicated than that. The anatomic correlates are not perfect. Add the complexity of coming to hospital and having an operation where the anaesthetist starts pouring lots of fluid directly into your veins, and the surgeon lets lots of fluid out of your veins, and the urine output goes down. So that struck me as a much better paradigm to be teaching people when it came to them wondering how it was that they could optimize, maximize the circulating volume, if you like, compared to the peripheral volume, which is where edema occurs. And it occurred to me, and this occurred to me relatively late, and I've explained it to Charles, and Charles is still not quite happy with it, so I'm going to try and persuade him over the day. It occurred to me that rather than thinking of extracellular fluid as intravascular and extravascular, we can think of it as free-flowing plasma and gel phase. Gel phase created by proteoglycans, glycoproteins, and glycosaminoglycans. And the importance of that is that the intravascular space contains some gel phase called the endothelial glycocalyx layer. And anything that gets into particularly the extravascular gel phase has to return to the circulation as lymph. So this is my pencil diagram, or my keynote computer-generated diagram of flowing plasma from an artery with some red cells bumping along here. These are the cell walls. There's an intravascular part of the gel phase through which fluid passes and albumin is filtered. Tight junction gaps through which the fluid enters the interstitial gel phase, then picked up into collecting or afferent lymphs. Going to lymph nodes, the anaesthetists I chat to in the operating theatre when I'm with them are entirely unaware that lymph nodes are able to pass fluid back into the circulation. And what doesn't get passed back into the circulation by lymph nodes up into the thoracic duct and return to the venous system that way. They all seem to know that lymph goes that way, at least. There, very quickly, I won't dwell on it, is from Rodney Levick's book. I said to Charles, what's the best textbook to read on this sort of thing? He very confidently said, this book is. So there you go. I recommend this to every anaesthetist and every intensivist and every medical student. The only thing I would say is it does say that colloid therapy is a good thing. So we've got to scratch that line out, Charles. All right. So I don't need to dwell on the Starling equation too long, except that anaesthetists like me hate equations. I got as far as grade C at mathematics, and that was O-level, I'm afraid. And when I said things that I thought were straightforward, Charles would come back to me 2 weeks later and say, I've done some modelling on that and you might have a point. So my mathematics is way below the level at which it's practiced by my esteemed physiologic colleagues. But here we go, that the rate of flux across the membrane is proportional to the hydrostatic pressure difference and the effective oncotic difference. Anaesthetists like me are more familiar with the concept of resistance. We have airway resistance, we have vascular resistance, and I think for transendothelial flow, it would be better if we substituted transendothelial resistance for conductivity, if that's all right with you chaps, and make the formula as simple as this, that the fluid flux per unit area equals the net filtration pressure divided by the transendothelial resistance, because then I can teach that a little bit easier. So here's my diagram again. Professor Pearce commenting on the problem of what to do if you haven't got starches in your cupboard. So one of our greatest challenges is keeping fluid in the intravascular space. So here's my proposal for how you do it. To keep fluid in this space here, you have to consider how you can reduce its leaving. You have to consider the net filtration pressure. That's going to be largely the capillary pressure, and Charles has alluded to how important that is. And the transendothelial resistance, keeping that as high as you can, will reduce JV to the peripheral volume of distribution. There are, of course, things that you can do to encourage lymph flow. We can have nurses massaging the legs. Curiously, noradrenaline increases contractility of muscles around lymphatic ducts, so that could be used too. And we can influence sodium and water retention or excretion. In volunteers and in anaesthetized patients, the volume effect ratio of crystalloid to colloid for causing anemia and hypoalbuminemia is about 5:1. In septic patients, in general intensive care patients, and in the intraoperative goal-directed fluid therapy, the volume effect ratio of crystalloid to colloid for the correction of hypovolemia is about 1.5:1. When you're looking at papers, ask, are they doing an experiment that looks at how well a colloid or a crystalloid dilutes the red cells or dilutes the albumin? And if so, expect a 5:1 effect ratio. If this is an experiment about how well a colloid or a crystalloid resuscitates the hypodynamic circulation, then expect a 1.5:1 ratio. Erythrocytes or albumin dilution data must not be presumed to indicate resuscitative effectiveness, and I've called that the colloid delusion. Here's a hypothesis that a bolus of an isosmotic plasma substitute has a central volume of distribution which approximates the free-flowing plasma. A bolus of an isotonic salt solution has a central volume of distribution that includes the intravascular gel phase and approximates the whole of the intravascular volume. This concept is supported by clinical reports of adequate resuscitation with plasma substitute being achieved with slightly smaller volumes than adequate resuscitation with a crystalloid, but at the expense of much diluted hematocrit. The ability of plasma and plasma substitutes to cause anemia is still widely misinterpreted as indicating that colloids are better volume expanders. Another practice point that small reductions in regional vascular resistance of a tissue bed below normal lead to substantial increases in capillary pressure and filtration. Capillary vasodilators, like alpha blockers, cause edema as a side effect. And alpha-1 adrenergic agonists, like noradrenaline, like phenylephrine, keep capillary pressure low by precapillary arteriolar constriction. They minimize delta P and therefore JV, and so they are effective anti-edema therapy. I have been finding, and I did not initiate this, I have been finding in my post-operative practice, patients are being brought back to my intensive care unit on a little infusion of noradrenaline. The anaesthetist says it just helps keep the pressure right, but of course what it actually does is keeps the capillary pressure down, keeps the filtration rates down, keeps the crystalloids that hopefully you're using effective and restricted to their central volume of distribution. Of course, the emergency treatment of anaphylaxis with adrenaline is the same sort of thing. That's why it prevents edema. It causes a really tight capillary vasoconstriction. A small point I won't dwell on too long, that we're not actually looking at the whole of the extracellular fluid space. We're actually looking at a relatively small proportion of it, which is in an anatomically expansile position that can contribute to the balance. There's fluid in non-expansile places which really doesn't contribute. Circulation of albumin is something that we don't teach, that we're really going to have to take into an account. Transported into the tissues, either convected through an imperfect filter that is the glycocalyx, or by diffusive caviolation, and Charles has already talked about these large pore channels that can move albumin in various ways. So we have a JV, the flux of solvent. We also have to think of JS, the flux of solute. And albumin, it has both convective and diffusive components. JS, I think of it as the transcapillary escape rate of radio-labeled marker, and as we've said, about 5% per hour. While JV is low, the transcellular pathway for JS predominates. But when hyperfiltration occurs, that pathway for albumin flux may predominate. I think I'm going to skip that one because we want to keep to time. I want to move on to the next practice point, which is that even in health, there is at any moment more extracellular albumin within the interstitial gel than there is in the plasma. I ask anaesthetists, where's the albumin? They say it's all in the plasma. They don't know that there is in extravascular albumin. During hyperfiltration and hyperpermeability, plasma albumin concentration falls because of a net redistribution of the circulating albumin to the interstitial space. Transfused albumin, the albumin you pour in, also redistributes at 10% per hour after surgery, 15% per hour in septic shock. So there's soon more of it in the tissues than in plasma volume. And excessive transfusion of albumin will overload the interstitium and cause edema. I mentioned this to Charles. He said, where did you get that from? I said, it's in every textbook, and I can't do more than tell you it's in every textbook. That every gram of albumin binds about 18 mils of water. I don't want to discuss that now, but I can tell you that's what we are taught, Charles. If you physiologists want to source it out, tell us otherwise, please do. So this is the important bit. Resuscitation from low intravascular volume and low capillary pressure. As JV is close to zero at low capillary pressure, plasma volume expansion from hypovolemia can be achieved with anything. As my colleague in Australia would say, you can achieve it with dog pee. Isotonic salt solution, an isosmotic albumin solution, or a plasma substitute, it really doesn't matter. It's only when capillary pressure has been restored to the point at which the convection of ultrafiltrate emerging from the junction strands has maximized the opposing sigma delta pi that further fluid loading will lead to a proportionate increase in JV. And I just called this relationship a J curve, and I suggested that the inflection point, we called it a J point. So there it is. While capillary pressure is low, then giving fluid to increase the capillary pressure, whether it's high colloid osmotic pressure or low colloid osmotic pressure, really doesn't matter. The distinction between colloid osmotic pressure containing fluids only becomes relevant when you're talking about taking patients into hypervolemia, when you're talking about trying to cause pulmonary edema. You want to cause pulmonary edema, get yourself a colloid, because that will push them fastest up towards high filtration rates. But below the J point, any transfused fluid will appear to be retained within its central volume of distribution. Slightly bigger picture here, that below the J point, the Michel-Weinbaum model operates. There is no reabsorption, and filtration is kept very, very low. And whatever fluid you give, you will just keep increasing the volume, the central volume, until you get here. And then the colloids and the crystalloids will make a difference. It's context sensitivity. The more severe the hypovolemia, the stronger the case for preferring crystalloid resuscitation. That will flush proteins from the subglycocalyx protected space, and it will repay the autotransfusion that occurs for 5, 6, 7 minutes perhaps when you have very, very acute vasoconstriction or very, very acute reduction of blood volume. This logic runs counter to the suggestion by some authorities that colloid solutions may be preferred in more extreme cases of hypovolemia because it stays in the circulation longer. Stat boluses of fluid, and we are doing that in anesthesia intensive care. We're giving stat boluses rather than trying to resuscitate a bit more gradually, but stat boluses may cause transient peaks of capillary pressure that will lead to transient hyperfiltration and actually ruin the effect for us. Slower resuscitation may be more effective. Just very finally then, what does regulate plasma volume? Plasma volume is upregulated, increased by the renin-angiotensin-aldosterone system, and through sodium and water retention via aldosterone and vasopressin and reduced urine output, and angiotensin II receptor mediated vasoconstriction, which reduces capillary pressure and so reduces JV. Plasma volume is downregulated by natriuretic peptides. Atrial natriuretic peptide is secreted in response to atrial distension and acts on intrarenal and extrarenal guanylyl cyclase A receptors to reduce the effective plasma volume. So while intrarenal GCA receptor stimulation increases natriuresis, extrarenal receptor stimulation increases the transcapillary escape rate of albumin, so that the delta pi opposing JV is not increased by the loss of salt and water from the circulation. So I put that for anaesthetists on a fairly simple little chart. We would like to think we can modify the capillary pressure, the area for filtration, renal sodium and water handling, and interstitial dynamics. And we have got the renin-angiotensin aldosterone system. We've got the vasopressin system. We can infuse vasopressin these days if we like. We've got sympathetic tone. We are infusing noradrenaline and phenylephrine. The natriuretic peptides increase capillary pressure, increase the area for filtration, have us lose salt and water. Histamine, inflammatory mediators. And this holds out some wonderful things. I think that Curry and Adamson saying now, they read my paper, I was thrilled about that, that there's now re-examination of the long-standing controversies in fluid therapy. They are looking at tonic regulation of vascular permeability, minute-by-minute regulation of vascular permeability, because it can change really, really fast. The layered structure of the endothelial barrier requires continuous activation of signaling pathways by sphingosine-1-phosphate and intracellular cyclic AMP. These pathways modulate, and I highlight these because I think I want to get these into anaesthetic teaching, knowledge of the adherens junction, knowledge of the tight junction strands and the gaps between them, and knowledge of the balance and synthesis and degradation of glycocalyx components. And I suppose too, the influence of small GTPases, which regulate minute by minute the permeability, appear to regulate minute by minute the permeability of this barrier. In inflammation, which we're interested in, because almost all our surgical patients and all our intensive care patients are inflamed, small GTPase activation is reduced, and sphingosine-1-phosphate and intracellular AMP are elevated. They can buffer the changes. Or, if they're not already elevated, we can do something about it. Elevated S1P or intracellular cyclic AMP can restore the barrier by re-establishing the adherens junction, modulating tight junctions, and then helping the glycocalyx. A therapeutic potential there for keeping the hematocrit high, using crystalloids, not colloids, and perhaps for using phosphodiesterase inhibitors. Just in case I didn't make clear enough, sphingosine-1-phosphate is carried by red cells, so it's delivered by red cells. It also requires albumin. I won't worry about more extreme inflammation there. Albumin is a glycocalyx component, as well as a carrier of S1P, and is one of several proteins necessary for the integrity of the endothelial barrier. But laboratory experiments suggest that a plasma, a vascular concentration as low as 10 grams per litre, is enough to support the glycocalyx and its endothelial barrier integrity. And in Italy, a very large trial of septic patients showed there's no therapeutic advantage in trying to keep the patient's plasma albumin concentration greater than 30 by giving fluid. Even the brain has lymph. I thought it was a wonderful finding. And if I may just leave you with a question, Geraldine, because I think Charles alluded to the fact that you can absorb an injected saline, but you can't absorb the stuff that you filter. If you've been following what we've been talking about this morning, you will understand that that observation is correct. Absorption of isotonic salt solutions by the blood vessels is determined by the osmotic pressure of the serum proteins. And we know when we inject a bit of intramuscular morphine in a saline solution, it absorbs very quickly. But how is that observation compatible with the no reabsorption rule? And if you have understood, well, if you are really on top of what we've been talking about this morning, you will understand how that is compatible. I'll leave you with a mystery there. I'll answer it over lunch or any time during the day for those ones. Geraldine, thank you.